outside the hall to please come inside the hall. We'll be starting our session, scientific session shortly. Requesting everyone to please come inside the hall.
আজকের এই অনুষ্ঠানের মডারেটর ডক্টর পীযূষ কান্তি মণ্ডল স্যারকে আমাদের প্রতিষ্ঠানের পক্ষ থেকে রিসিভ করে নেওয়ার জন্য অনুরোধ করব। স্যার। এরপর স্যারকে রিকোয়েস্ট করব এই সমগ্র অনুষ্ঠানটি পরিচালনা করার জন্য।
শুভ সন্ধ্যা, good evening everyone. Today we have gathered here to attend a CME on low back pain and traumatic brain injury. we have two renowned speakers and renowned neurosurgeons of the state, Dr. Ujjwal Kumar Vishwas and Dr. Sudeep Kumar Ghosh, who will be taking us with several diagnostics and management, therapeutic management of low back pain and traumatic brain injury. For this, I first welcome Dr. Ujjwal Kumar Vishwas on the dais, and I request Pooja to welcome him with floral bouquet. We request all of you to have a round of applause. Next, I welcome Dr. Sudeep Kumar Ghosh, consultant neurosurgeon who is working at Park Clinic, Kolkata, Park Sonuscan. He is a senior consultant neurosurgeon. Formerly, he was attached with the BI in Kolkata. Thank you, sir. I request Dr. Amitav Mandal, the Deputy CME, to come to the dais as our guest. Please welcome Dr. Mandal with floral bouquet. Bosun sir. So after welcoming everyone in the dais, I request Dr. Ujjwal Kumar Vishwas to deliver his lecture on low back pain, traumatic brain injury. He is working in Sonuscan, Malda for a pretty long time. He is also attached with Malda Medical College as faculty of neurosurgery. So, sir, I request you to please take the dais and deliver your lecture. আমরা ওখানে বসি, আমরা ওখানে বসতে পারি।
Good evening, everyone. I am Dr. Ujjwal Kumar Vishwas. It's my great pleasure to be present here. At the onset, I would like to express my sincere gratitude to the Sonuscan team to give me this wonderful opportunity to express or share knowledge and experience with you. Today, I am going to discuss an important challenging topic in neurosurgical practice, and that is traumatic brain injury. Traumatic brain injury remains a major cause of death and disability nowadays in whole world. Early assessment, timely intervention, and appropriate management can significantly improve the outcome. I hope this session will be interactive and beneficial with all of us. First, near about 69 million people in world is suffering from traumatic brain injury every year. young adults and early elderly people are prone to injury more. They are more vulnerable in traumatic brain injury. Approximate 70 to 90% traumatic brain injury is mild. That causes no harm to people, are not causing death, but near about 50% death in traumatic brain injury occurs due to respiratory infection. Most common cause of death basically CNS injury followed by the bleeding. Near about 42% CNS injury causes the death in traumatic brain injury. Injury classification can be divided in 4 groups: mild, minor, mild, moderate and severe according to GCS score and loss of consciousness. If GCS score is 15 and there is no loss of consciousness, that is minor traumatic brain injury. Mild is 14 to 15 plus loss of consciousness. Moderate when the GCS 9 to 13 and severe when GCS is less than 8. Management pathway divided in 2 ways: primary survey and resuscitation, followed by secondary survey and imaging and definitive management. Primary survey, we all know the ATLS protocol, that is airway, breathing, circulation, disability and exposure. And this is very important, GCS scoring. Before 1974, different hospital practices different descriptive procedure like stupor, semi-coma, deep coma. But in 1974, Sir Tasdale and Brian Janet in Glasgow town, they developed a scoring system, that is Glasgow Coma Scale. In this, after that, there are so many modification has occurred. Now it is practiced as GCSP. Here the 3 element, basically 4 element: the eye opening if the spontaneously opened eye, then 4, to voice 3, to pain 2, and no response is 1. Verbal response means the patient is well oriented, confused, words, 2 words, sound or none. Motor response, basically we say it's the best motor response, that is obeys command, localized pain, withdrawals to pain, flexion, extension and none. Pupillary reaction is the bilateral reacting or unilateral reacting or not. So the EMB pathway, EMB minus P is the GCS score. Symptomatology. In mild traumatic brain injury, brief loss of consciousness less than 30 minutes. Time is very important because more than 30 minutes, if loss of consciousness occurs, then it is a moderate traumatic brain injury. Post-traumatic amnesia, less than 24 hours, headache, dizziness, nausea, confusion, disorientation, fatigue, sleep disturbance. In case moderate traumatic brain injury, here the GCS is 9 to 13. Here the loss of consciousness is more than 30 minutes, post-traumatic amnesia more than 24 hours. Persistent headache, vomiting, focal neurological deficit and seizures. In severe traumatic brain injury, where the GCS less than 8. Deep coma and unresponsiveness, this basically occurs due to damage the reticular system of the brain. Decerebrate and decorticate posturing, where the posturing occurs, decorticate posturing, where the flexion of the upper limb and extension of the lower limb occurs. Because if there is a traumatic brain injury, brain edema occurs, in that cases the central herniation occurs. Central herniation means the displacement of the brain tissue from one compartment to another compartment. Here the central herniation, there is tentorium or through the foramen magnum, brain stem or the temporal lobe that herniates. And in case of herniation, the rubrospinal, if there is a herniation above the rubrospinal tract, then there is decorticate rigidity, and if there is a vestibulospinal tract is affected, then there is cerebrate rigidity. And the pupillary abnormality, this is also very important. If there is uncal herniation, if uncum is the medial portion of the temporal lobe that herniates through the tentorium cerebri, and it causes the pressure on the third nerve. The periphery of the third nerve is parasympathetic supply. The parasympathetic supply, this causes the constriction of the pupil, but if there is herniation, then the damage of the parasympathetic nerve that causes the dilatation of the pupil. Actually, there are dilation of pupil along with the drooping of the eyelid and divergent squint and diplopia. The fourth thing occurs, but the clinical scenario we only see the drooping of the eyelid and the dilatation of the pupil. And the hemodynamic instability. But we have to remember the red flag sign. Red flag sign is a deteriorating of GCS. In patient care, deteriorating of the GCS means fall of GCS score more than 2 or 3. This is very important because the surgical treatment or other management will depends on this. Unequal pupil, Cushing triad. Cushing triad means if there is any intracranial hypertension, then the internal hypertension, arterial and the artery that compresses the edematous tissue. To overcome that, the hypertension developed. In case of hypertension, the carotid baroreceptor that is activated, and that parasympathetic pathway, the bradycardia develops. Means, and irregular respiration that occurs due to herniation. There are 4 types of respiration seen: chain stroke respiration, apneustic breathing, chaotic respiration, and central chaotic respiration. আমরা সবাই মানে হসপিটালে বসলেই একটা কথা বলে যে আসলো একটা সিটি স্ক্যান করে দেন। ইভেন যে সই করতে পারে না, মানে লেখাপড়া যায় না, আমি ছোট করছি না, তারাও এসে বলবে যে মাথায় চোট লেগেছিল একটা সিটি স্ক্যান করে দিন। তো কিছু গাইডলাইন বাবুরাও ইসের থেকে লিখে দেয় হসপিটাল থেকে যে একটা সিটি স্ক্যান করুন। তো দিস ইজ দ্য গাইডলাইন অফ সিটি স্ক্যান ইন ট্রমাটিক ব্রেন ইঞ্জুরি। GCS at any point less than 13, কোনো বইয়ে আছে less than 12, less than 13, GCS less than 15 after 2 hours, vomiting more than 1 hour. এটা চেঞ্জ হয় বাচ্চাদের ক্ষেত্রে, যেটা more than 4 episode of vomiting, আমি পরে আসবো। Post traumatic seizures, focal neurological deficit, sudden onset suspected open or depressed fracture or basilar fracture. Basilar skull fracture আমি পরে আসবো, যে কিছু সিমটমস হয় যেমন CSA প্রাইনোরিয়া, CSA পোটোরিয়া, রেকুনাই, ব্যাটেল সাইন। ইমেজিং ক্রাইটেরিয়া imaging criteria within 8 hours. If the age is more than 65, patient is taking aspirin or warfarin or any coagulopathy, dangerous mechanism of injury, and retrograde amnesia more than 30 minutes. CT findings. In 1967 to 1961, Sir Garfield Hansfield developed the CT scan, and for that he awarded Nobel Prize in 1979. And the CT scan still now the gold standard procedure of investigation procedure of choice for traumatic brain injury. After development of CT scan, there are so many development has occurs. That is a single slide, helical slice, and then now it is multi-retractor CT scan come. CT findings is epidural hematoma. Epidural hematoma is biconvex hyperdense collection. Actually, the biconvex hyperdense collection occurs only 84% of cases. It may be occurs crescent-like with 5% or one side convex and other side straight, that is 4% cases. So it doesn't mean that the every EDS is biconvex in nature. Subdural hematoma is crescent shaped. One thing, subdural hematoma crosses the suture line, but it does not cross the farce. And brain contention and diffuse axonal injury pattern. Skull fracture is a linear fracture, depressed skull fracture and basilar fracture. Basilar fracture indicates আমি আগে বললাম যে হিমোটেম্পান, CSA প্রাইনোরিয়া, ওটোরিয়া, বেটেল সাইন, রেকুনান্ট পান্ডা সাইন. Epidural hematoma. Epidural hematoma basically occurs in traumatic injury, fall from height, whatever. There is a lucid interval. Here the patient become unconscious the immediate impact. After that patient regain consciousness, and after that patient loses his consciousness. This occurs in দুটো theory basically. যে একটা যেটা হচ্ছে most common cause of epidural hemorrhage is middle meningeal artery rupture. একটা থিওরিতে বলছে যে মিডল মেনিঞ্জাল রাপচার হলো, তারপরে ধীরে ধীরে ব্লাড কালেকশন হলো এপিডুরাল স্পেসে, তারপরে কি হলো যে যে কালেকশন হতে যে টাইমটা লাগছে ওই টাইমটাকে লুসাইড ইন্টারভ্যাল বলছে। আর একটা থিওরি যেটা আগের থেকে ট্রমার সময় পুরা সেপারেট হলো ইনার টেবিল অফ স্কাল থেকে, তারপরে ব্লাডটা কালেকশন হলো। সো টু থিওরিজ দেয়ার হোয়াইল লুসাইড ইন্টারভ্যাল ইজ প্রেজেন্ট. Surgical indication of epidural hematoma is more than 30 ml of hematoma. If GCS less than 9, কোনো বই less than 8 আছে। তো প্র্যাকটিস কে কি রকম করবে তার উপর ডিপেন্ড করে। Thickness more than 1.5 mm and midline sheet more than 5 mm. Subdural hematoma. Subdural hematoma occurs due to rupture of the bridging vein. Surgical time of intervention is thickness 1.5 ছিল, এখানে more than 10 millimeter. Midline sheet same more than 5 millimeter.
TCS drop or NIC Korea with ICP more than 20 millimeter mercury and thickness more than 10 millimeter. Depressed skull fracture. This occurs actually when the traumatic force is concentrated to one small region of the typically fractures are conservatively managed, but the surgical indication is fracture. The depression fracture segment is more than the thickness of the skull, possible wound contamination or dural bridge, fractures involving frontal sinus or CSF leakage. Only brain injury where the MRI is the investigation of choice, because their DWI image or SI image, the gray-white junction, here basically occurs the shearing or tearing of the white matter. So it better seen in MRI. Principal management. Principal management is control of ICV, seizure prophylaxis, nutrition and venous thromboembolism prophylaxis, and outcome monitoring rules. ICP, targeted ICP is less than 20, normal ICP 5 to 15 millimeter of mercury. Target cerebral perfusion pressure is more than 60. Targeted ICP, targeted mean arterial pressure 80 to 90 millimeter of mercury. ICP management. Here IC managed tier 1, tier 2 and tier 3, but no one bothered about the level 0 or tier 0. Tier 0 is also very important. I have to focus on level 1 but tier 0, level 0 but tier 0 management. Here after A, B, C, D, E, elevation of the head in bed 30 to 40 degree, make in neutral position. Neutral position that causes the lower pressure on the jugular vein and that decreases the intracranial pressure also. Adequate oxygenation, SpO2 more than 94%. Normocapnia, PaCO2 to be remain 35 to 40 millimeter of mercury. And cerebral perfusion pressure to be 60 to 70 millimeter mercury. Treat fever, any agitation of the patient, hypoglycemia and hyponatremia. Because hypoglycemia, hyponatremia also increases the ICP to increase the brain edema. After that, the level on management or tier on management, that is sedation, CSF drainage. We do a EVD, external ventricular drainage, in this Cocker's point, here midline 2.5 centimeter from the midline and the coronal suture 1.5 centimeter. That is point, that is the Cocker's point. Here we put a external ventricular shunt tube and CSF pumps out and that decreases the intracranial pressure. And the hypertonic saline. Level 2 management, neuromuscular blockers and repeat CSF drainage and mild hyperventilation. In case of hyperventilation, the carbon dioxide washed out. That decrease PaCO2, that causes the vasoconstriction. According to Monroe, Kelly and doctrine formula, theory, brain is a closed chamber which contains the three things: brain parenchyma, CSF in ventricles and vessels, means blood. If there is any component is compromised, then the other component hampered. So in hyperventilation, the vasoconstricts and the cerebral pressure, intracranial pressure is reduced. That's why the hyperventilation is cannot do prolonged time. This is very short period. Decompressive craniectomy. This is the last level, level 3. In case of ICP, more than 25 millimeter mercury, despite the practice of 1 and 2 tier, malignant MCA infection with mass effect, large contusion and herniation results. এখানে চিলড্রেনদের ক্ষেত্রে একটু আলাদা হয়। চিলড্রেনদের ক্ষেত্রে সিটি স্ক্যানের রুল মানে যেমন বলেছিলাম যে মোর দেন 1 টাইমস যদি ভমিটিং হয়, এখানে মোর দেন 5 এপিসোড অফ ভমিটিং যদি হয় তাহলে বাচ্চাদের হয়। আরো কিছু আছে যদি ব্রুইজ, ল্যাসেরেশন, সোয়েলিং মোর দেন 5 সেন্টিমিটার আন্ডার 1 ইয়ার, that is also indication for CT scan. GCS less than 15 2 hours post injury, that is also indication for CT scan. আর সব একই। After surgery, neuro rehabilitation is necessary. It is multidisciplinary basically. Acute rehab, cognitive therapy, physical therapy, and return to activity. Complication means the intracranial infection, CSF leaks, penetrating trauma, basilar skull fracture, hydrocephalus. Post-traumatic epilepsy occurs only 15 to 20% cases. Take-home message: assess the nature of injury clinically. Look for any deterioration of GCS, pupils, or hemodynamic status, advise CT scan if the patient fits the criteria for imaging. Counsel the patient's attendance. Non-contrast CT is the imaging of choice, and evaluation of the patient following CT report. Assess if the patient requires CC care. Refer the nearest trauma center with neurosurgical facilities without delay. Last all, I want to say clot in head injury does not mean the surgery, and operation does not mean the cure. Thank you.
Thank you very much, Dr. Vishwas, for taking us to this important topic on brain injury, traumatic brain injury, which we often encounter in day in and out. We'll be taking questions after the second talk is over. We'll be taking questions after the second talk is over. Now I welcome Dr. Ghosh to talk on an important topic, Dr. Sudip Kumar Ghosh, to talk on an important topic of low back pain, which is one of the most important and most frequently encountered symptom. At least we physicians encounter a substantial number of patients in our daily practice. So Dr. Ghosh will be taking us through this low back pain. Welcome, Dr. Ghosh. The stage is yours.
Thank you, sir. Good evening, everyone. So, we are primarily here to discuss on the low back pain. Why we have selected this topic? So once again, good evening everyone. So we have primarily selected a very common symptom in today's date. A lot of patients do come in our clinic with low back pain. Not just in the clinics of orthopedic surgeons or neurosurgeons, in the clinics of all type of doctors, starting from general practitioners. They come with a very common symptom, komore batha korche. So we need to identify which comorbid batha should be and what it is, how it should be evaluated, whom to send it to for further management. Because in today's date, low back pain has become one of the most common cause of medical absenteeism. It is highly rated cause of medical absenteeism. First. Second, because more number of cases are coming in our clinics with low back pain. বিভিন্ন রকম পেশেন্ট আসবে with বিভিন্ন রকম features, like they will tell you কোমরে ব্যথা. Now as a physician we should be asking the patient about the symptomatology in details, whether the pain is localized, whether it is radiating to a leg, whether the pain is increasing on walking, on climbing stairs, or it is just in the low back increasing by turning on your bed. মানে ব্যথা যখন ডান কাত বাঁ কাত হচ্ছে তখন বেড়ে যাচ্ছে. So these all kinds of pain that I explain করলাম has got particular name behind it. So the first one is a localized low back pain. It can happen. It is the commonest one. It happens with almost everyone. Everyone has faced this once in their lifetime. Localized low back pain. Radiculopathy, when one of the roots of the lumbar plexus carries the pain along the posterior part of the leg to till the sole. That is called radiculopathy. Why this happens, I will explain it later. In neurogenic claudication, again, with our basic training, we know what is claudication. It is divided in two parts, might be vascular, might be neurogenic. The conta neurogenic, conta vascular, rather than differentiating that, I am trying to explain what is neurogenic claudication. The patient will tell, খুব ভালো করে আমার ব্যথা আরম্ভ হয় কিছুক্ষণ হাঁটার পরে, ব্যথা আরাম পাই আমি যদি বসে পড়ি বা একটু রেস্ট নিই. আগে যতটা আমি হাঁটতে পারতাম এখন অতটা হাঁটতে পারি না. আগে 100 মিটার হাঁটতে পারতাম ব্যথাহীন, এখন আমি 50 মিটারে আমার ব্যথা আরম্ভ হয়ে যায়. So this is called neurogenic claudication. আর মেকানিক্যাল ব্যাক পেন, এই মেকানিক্যাল ব্যাক পেন কথার অর্থটা হচ্ছে কোমরে প্রাথমিকভাবে কোমরেই ব্যথা বা পিঠে ব্যথা, ব্যথাটা বাড়ে আমি চেঞ্জ অফ পোশ্চারের সাথে। প্রাইমারি when you sleep and patient rotates on the bed, তখন কোমরে ব্যথা বেড়ে যাচ্ছে, অথবা পেশেন্ট বসে রয়েছে একটু উঠতে গেল প্রচন্ড কোমরে ব্যথা বেড়ে গেল, দ্যাট ইজ কল্ড মেকানিক্যাল লো ব্যাক পেন। তো প্রাথমিকভাবে এই চারটে জিনিস নিয়ে পেশেন্টরা আমাদের কাছে আসে, যেটা আমি এখন এক্সপ্লেইন করলাম। That is dull or achy, contains the low back localized, radiculopathy, iglo. I have just copied this table from the book, needless. আমার মনে হয় না it is দরকার। So coming to the reasons, the most common reasons as per tabulation is, I told you localized low back pain, everyone has faced in their lifetime once in their life. The most common reason is sprains and strains, the musculoskeletal problems, the muscular strain, কিছু কাজ করতে গিয়ে মাংসপেশিতে টান ধরলো, that is the most common cause. Further, there are other causes like degeneration which involves disc disease, herniated disc, sciatica খুব commonly আমাদের আজকাল তো চ্যাট জিপিটি থেকে পেশেন্টরা আমাকে বলে কি তাতেও আমার sciatica ব্যথা হচ্ছে। But the sciatica is a very medical term which involves pain along the sciatic nerve. Spondylolisthesis, spondylolisthesis, again this medical term means when the vertebral alignment is changed, a spinal canal stenosis, যখন the diameter of the spinal cord is compressed, it is lessened, lowered, what আমরা stenosis বলি। তো এই সব হচ্ছে, these are the causes with which a patient comes to our clinic for low back pain. So I explained the character, what they present with, what the possible causes. Now we go on to understand the symptomatology. What are we supposed to ask? What do I ask? First is, as we have read in our primary training period, key classify pain, define pain, elaborate the pain. ওই পেইনটাকে elaborate করতে হবে, কিরকম ব্যথা, কখন ব্যথা হয়, কোন কাজ করলে বেড়ে যায়, কি করলে কমে যায়, কোথায় ছড়াচ্ছে, what is the character of the pain. So that is what, whether it's dull aching or sharp shooting, how the pain progresses, কতদিন ধরে আস্তে আস্তে বাড়ছে, what are the aggravating, the relieving factors, postural relation কিরকম হলে পারে, diurnal variation, this is very classical. অনেকে বলবে সকালে যখন আমি ঘুম থেকে উঠি পুরো আমার কোমর আড়ষ্ট হয়ে থাকে, ব্যথা প্রচন্ড থাকে, we need to have a thought about the rheumatological causes also. When there is extreme amount of spasm early in the morning, along with I told you radiation of the pain along the thigh, claudication, এগুলো হতে পারে। And what are the associated symptoms? Yes, numbness, পায়ে ঝিঝি ধরছে কিনা, there is tingling, পায়ে অসাড় হয়ে যাচ্ছে কিনা। Other than that, we also need to ask certain findings like the bladder and bowel control, whether he is having any kind of urinary symptoms, whether there is any urgency, any kind of hesitancy, whether a sense of incomplete evacuation. This all features, these particular three things, urgency, hesitancy, and a sensation of incomplete evacuation. These three things has a neurogenic bladder in component. So these are the red flag signs that requires immediate attention. First is, as I told, loss of bladder and bowel control, recent weight loss not due to lifestyle changes, fever and chills, severe unrelenting pain or foot drop. এটাকে যদি সামারাইজ করতে চাই, I can tell you practically three signs and symptoms you will be getting classified as red flag sign. One is this loss of bladder and bowel control first. Second is progressive neurodeficit or sudden onset neurodeficit like foot drops. And third is very important, called saddle anesthesia. The patient themselves will complain that I am not getting any kind of sensation, or there is a numbness, heaviness all around the buttocks, I cannot feel my genitalia, they will themselves tell it. So this is a classical red flag sign with the lower back pain. You need that patient needs immediate attention. Then we go on for investigations. তখন আমরা রোগীকে জানি হ্যাঁ এবার আমরা পেয়েছি। So this is the way we go on. First is the history. We have learnt it in our school days, in our MBBS school days. First is the history. Adding to that, we need to also ask the addiction history. That is very important for a low back pain. Signs. we examine the patient for neurodeficits, the muscular deficit, the sensory loss, the reflexes, whether it is lost or present. So these three things are checked. Stress test, I have written that is classically a root stress test. We give certain investigations like blood, actually localized low back pain, muscular strains and sprains. The endemicity of vitamin D3 deficiency is proving a toll on the low back. It is an endemic vitamin D3 deficiency, don't know, chronic low back pain. There is a chronic musculoskeletal pain, but the patient presents mostly with low back pain. Then hypothyroid, like metabolic disorder, hypothyroid, diabetic, obesity, all this is also includes low back pain. The rheumatology profile. So these things needs to be worked up. We get a dynamic X-ray. It's not just a static X-ray. I'll tell you, please. We just prescribe X-ray. কোমরের মূলত কাজ হয় যখন আমরা বসি বা দাঁড়াই. So always try to advise a standing X-ray when it is a weight-bearing way, in a weight-bearing fashion. Most of the X-ray centers, they do a supine X-ray. That is not very much helpful to us. So that is called dynamic X-ray. Kaake boli? Jahan along with standing, the patient bends forward and extends backward. In that lateral position, the X-ray is taken. It is very informative. X-rays are very informative. According to the X-ray, we go on to go with MRI. This is the investigation of choice. There is no doubt. MRI will reveal whether there is any neurogenic, whether the nerve is getting compressed, whether there is any stenosis in the canal, whether the disc has migrated or extruded, what is the condition of the bone. It gives a very clear anatomy of everything. CT scan if at all required. In certain cases it is required, if at all required. These are the ways we do the examination physically. I mean, by asking the patient to bend forwards, then we go on to examine the various root level examination, the characteristic root level examination that we gave from L1 to L5 along with S1 to S4. That is, I told about the lumbar plexus, that is L3 to S1, but we go on to examine all the nerve root fibers right from L1 to S4. It gives an indirect evidence whether this is matching with our MRI picture or not. So these are certain cases where I showed in the first picture. I have shown you is a list, the arrow mark, flexion A. There is a list. This is the 3, 4. The arrow mark. If you see the posterior end plate of the vertebra, there is a gap between these two, L3 and L4. The patient while extending, it is coming back. So এটাকে বলা হয় spondylolisthesis. And everyone can identify this. It's very common that we get in our practice. It's a huge disc prolapse at the level of L4-5. And post-surgery, if you find post-surgery, the disc is gone, the patient is symptomatic, and will give you with lots of blessings, lots of gifts, whatever you want. So once we investigate and find what are the things that is happening, we go on to the treatment part. So the first is, I told you most of the pain is localized musculoskeletal pain that does not require any surgical attention. So what we advise, at times we advise short rest period, lifestyle modification. Aajkal ki sedentary lifestyle is the root cause of the low back pain. Sedentary lifestyle. So we ask the patient to go on for rehabilitation purpose, activity modification, drugs such as we give certain kind of analgesics, muscle relaxants, and those are very helpful. Classically, in the historical era, from till prehistoric date till now, from the advent of a drug called amitriptyline, for whatever it was discovered, it is a very classical and very good drug if you prescribe it for low back pain. It gives a good amount of muscle relaxant. It has got a criteria. So there are certain exercises I have just picturized here, but leave it to the PMR doctors and the physiotherapists. They know it better than us. Surgery part. So for the surgery, I'll tell you the indications. So it is an interactive session. So I'll go on to tell you the indications for surgery. Just as I told, the red flag sign. Sudden onset of severe excruciating pain. There is a foot drop. There is loss of bladder and bowel control. There is sudden anesthesia. We investigate. We find a disc prolapse. There is no point in waiting for the patient. We just go ahead and go on to operate the patient. The primary aim of the operation, the primary aim of the surgery is nerve root decompression, or relieving the canal stenosis, or aligning the bones back in their own position. So these are the primary aim of the surgery. How do we do it? Various ways are there. These are the ways that we do. But that is the primary aim. We do microdiscectomy. We take out the disc, the disc causing the problem, the nonsense disc that is causing the problem, we take it out. If at all there is a stenosis, we find that there is a canal that has got compressed. We do a laminectomy, flebectomy, discectomy, we do a lot of things. Along with that, sometimes we go on to use certain kinds of implants like pedicle screws, cages. We don't tend to fuse the vertebral level. যখন একটা mobile vertebra থাকবে, what we do, we go on to fuse that level. That is, there is complete loss of mobility in that level, and there is pain reduction. Both the things at the same time. Certain examples of the MRI. This is the way we fix it. We have done a fixation, not a fusion. So, thank you. Any kind of questions? Because this is a topic that needs to be discussed in details rather than presenting it. What I suppose is this: low back pain is a chronic disease in today's day. It is at pace with all the metabolic disorders that we are facing. Thank you.
Thank you. Thank you both the speakers for your lucid presentations. And as we know, the low back pain is important and very frequently encountered symptom that we all practitioners are facing in our daily practice. Hopefully, these two talks has enlightened us to improve our practice. And if there is any questions regarding this topic, we'll be happy. Please, sir.
It was a very enlightening discussion. Thank you for that. You outlined 4 types of predominantly common, if I'm right, low back scenarios, low back pain scenarios. I would just like to ask you, in some malignancy cases there are metastases like prostate C and all. So in what way do they present to us, and when should we suspect that this might be a metastatic bone pain?
Good question. So I didn't discuss about the tumor issues. I was thinking about discussing the tumor issue, but I thought of covering the commoner things first. Anyways, metastatic spine disease is again a common one, getting primarily from the prostate, lungs, breast, liver. So I did mention about a symptom called mechanical low back pain. So the patient primarily will present with, it is an extradural component, the bony metastasis. They primarily present with a mechanical low back pain, mechanical pain. Along with that, they will be having the other signs and symptomatology of the primary tumor. So weight loss or any kind of bleeding from the genitourinary tract or the GI tract, any kind of weight loss, or all the other things that is related to the primary tumor. So once we get a picture, once we get an X-ray, we can find there is a compression fracture or any kind of osteolytic lesion is there. Then we go on to do the MRI. Sometimes we go on to do the CT grade FNAC. That gives us a clue whether there is a neoplastic metastatic lesion or not. First, at times, what we do when we find in the MRI there is already a compression element because of the tumor, of the metastasis, we don't go for a CT grade FNAC anymore. We directly counsel the patient that you have to undergo surgery. In the surgery, we'll take primary biopsies to prove that is also related to the primary tumor. So this is the way. So mechanical back pain also covers that part also.
Sir, in low back pain, we frequently advise to the patient that lumbosacral belt, you were not mentioning about this, is it good or not?
Lumbosacral plate.
Belt.
Oh, brace. braces are not required for everyone. It is very selectively required. We tend to overuse and misuse it. Brace is practically required for those patients which is having a mobility in the lumbar segments like listhesis, or when we want rest after surgery for a few weeks, nothing more than that. Because effectively what brace does is, it weakens the muscular segment. It is bearing the weight of the body. Brace distributes the weight between the muscles and the brace. So the activity of the muscle decreases. We do not advise braces for a long term. Definitely not.
Any other questions, please?
What is the role of physiotherapy in low back pain?
Important role. The most important role, in fact, I'll tell you, that is the physiotherapist role is much more important than the surgeons also. We tend to identify, but their work is to do. 95% of the cases do not require surgery. They tend to improve with physical rehabilitation.
What type of physiotherapy is needed for this?
The primary kind of physiotherapy that we usually advise is the pelvic bridging, low back, core muscle strengthening exercise. Core strengthening exercise is very important. I mean, removing the spasm from your hamstrings and the quads, then the pelvic floor re-strengthening. This kind of exercise we prescribe, but these are actually taught by the physiotherapists. How to do it, which patient will do the pelvic bridging till which degree, is all important. So this is the idea of the physiotherapist to do it. We just prescribe the patients to go to that physiotherapist. What are the exercise he requires, we write it down, he will show it and educate them.
Thank you.
Dr. Bhagat, our physiatrist.
Thank you for your excellent presentation. My question is to know that if some patients come with persistent low back pain along with radiculopathy and they are being managed well with conservative management, but the MRI findings is showing that there is a canal diameter which is indicative of surgery, but the patient is managed very well with conservative treatment. What is your opinion? That canal diameter is 7, 8 kb canal diameter. What is your opinion regarding this patient?
Patient is being managed well, is
Managed well
persistent low back pain with radiculopathy, you told.
Radiculopathy and the low back pain both are managed well with
conservative management.
But the canal stenosis is
My personal idea, I always treat the patient, not the scans. Okay? I do not tend to treat the scan. Scan might have a lots of features, scan might have a lots of important findings. But my idea is to treat a patient. If his pain and everything, radiculopathy is being managed well with a conservative management, why do I need to put a blade on him? But if the patient is having neurodeficit, that is my way to find it. If the patient comes with neurodeficit, or the patient may land up in neurodeficit, then I have to counsel that is surgery for a bhalo. But in this case, that the case that you have explained, canal diameter 7, 8, I don't treat the scan. I treat the patient.
Thanks, sir.
I have got 2-3 questions to you. Number one, if the patient has got vitamin D deficiency, so what is the prescription you normally do? Number one. Number two, what is the role of non-block, trigger block? The second, when you do it, and when you go for an epidural anesthesia, epidural block, because the patient has come with a radiculopathy, as he said, with a MRI, which doesn't show much disc lesion, but the patient is having epidural anesthesia, which is steroid. Do good. So, what is your experience about these three?
So the first question, the answer to the first question is, when there is a vitamin D3 deficiency, please take your seat, I'm expecting. When there is a vitamin D3 deficiency, how do I manage it? So I have learned it from the endocrinologist. Practical vitamin D3 deficiency doesn't come in isolation. It comes with certain other features also. Just isolated vitamin D3 deficiency, I manage it with 12 weeks course of once a weekly 60,000 dose of vitamin D3 along with a daily dose of 2,000 international unit of vitamin D3. And then again check the level after 3 months. It is a standard daily practice. Not written in any kind of neurosurgical books. I have learned it from my endocrinologist friends and seniors. First is this. The second question was very important. In fact, I can amalgamate both the questions, the root block and the epidural block. Root block in all purposes, it is called selective nerve root block, SRN, selective nerve root block, and the epidural analgesia. So, for selective nerve root block, there is primarily two indications. Only two indications are there for selective nerve root block. One, first, if there is any kind of diagnostic dilemma. If I am in a dilemma to frame a diagnosis, my findings are not matching with the MRI picture. The patient complaint is not matching with the MRI picture, then there is a diagnostic dilemma. So first is that when I give a root block. Second is post-operative radiculopathy. So primarily I find in our neurosurgical practice, we have found that these two is a primary indication for selective nerve root block. And epidural analgesia, sir, again, it carries lots of indications that have shown that localized low back pain, musculoskeletal pain, all this kind of sprains, strains, they carry good outcome with the epidural analgesia. Otherwise, for any anatomical finding, if I get in the MRI and that is supported well with a neurodeficit, the ideal treatment of choice is to go ahead with the surgery. If there is a neurodeficit and it is being supported with the MRI scan, then go ahead with the surgery. No point in giving any kind of root block. Lots of things are being done, but it's basically this carries only two indications. There is diagnostic dilemma and post-operative pain, persistence of pain.
Thank you. Thank you, sir. Any other questions? Dr. Sanal.
You have mentioned that inclusion of thyroid profile in routine workup of low back pain. How do you relate thyroid diseases with low back pain?
Obesity.
Is that obesity too high?
It's not just obesity. I told you this metabolic syndrome encapsulates entire thing. Gradually, you will find in a few years from now, low back pain is being included in the metabolic profile. I mean, তোমার কি কোমর ব্যথা আছে রোগীকে এখন জিজ্ঞেস করতে হয় তো obesity, hypothyroidism is strictly related to obesity. Hypothyroidism, patient we find quite common and they come with muscular sprains. I do not know the reason why, but hypothyroid patients they come with muscular spasms quite frequently. So it has come in our routine practice with a low back pain patient to include a thyroid profile.
But then this has impact on bone mineral density or
no? Probably you are right, absolutely, because myopathy is associated with both hypo and hypothyroidism. So in both cases, back sprain may occur. So it's not probably due to the.
I'm practically a surgeon, sir. I have a very little knowledge regarding this medical issue.
I am incidentally an endocrinologist, so it matches. Your thought process matches with mine.
Yes.
Thank you, sir. Thank you for enlightening me.
If there is any other questions, I have a question to Dr. Bishas. Sir, whether how frequently do you prescribe anti-epileptic drugs in patients who are having traumatic brain injury, and how till when do you prescribe this?
Traumatic brain injury, seizure two রকমের হয়, early onset seizure and late onset seizure. Traumatic brain injury যেগুলো early seizure develop করেছে ওগুলোকে আমরা 3 years seizure prophylaxis দিই, কিন্তু যদি seizure না হয় prophylaxis only 7 days, after that can stop. But if you start delayed onset seizure, যদি 7 days পরে হয়, you have to continue for 3 years.
Sir, আমাদের কোন এরিয়াতে যদি ব্লিডিং হয় বা কোনো ইনজুরি হয়ে থাকে ব্রেনের কোনো এরিয়া পার্টিকুলার এরিয়া যেখানে আমাদেরকে প্রথম থেকেই অ্যান্টিএপিলেপটিক্স নিতে হয়, এরকম কোনো এরিয়া?
Actually, temporal lobe হলে সবথেকে বেশি ইন্ডিকেশন অফ seizure.
So, is there any other questions? Yes, sir, please.
Sir, thanks a lot. It's very authentic and informative lecture regarding low back pain. But I have some confusion regarding low back pain. That, sir, can renal stone can cause the low back pain, and what to do next?
Sir, treat the renal stone.
Yes.
If renal stone is a cause of low back pain, you treat the renal stone.
Yes, sir. I have seen in several cases there is no cause, no any symptom, but patient suffering from low back pain, and when they stooping forward or lying down, they are feeling some pain. And I studied X-ray, MRI also. There is no abnormal, normally study, but patient suffering something pain, low back. Sir, can we suspect renal stone?
No, sir. I mean, not exactly. Renal stone, the pain characteristic of renal stone is very, very nice. I mean, it has been described in a very lucid way that it might be if there's a pelvic ureteric junction stone, groin to groin pain, it is just localized to the renal cortex. There is localized pain, but not in the midline. It is much more in the lateralized pain. So renal stone pain is something different from a low back pain that we are talking about. Low back pain, but it does involve. It is not different for the patient. It is different to us. Komor batha nahi hai, for the doctor it has to be different. But for the patient, kamar to komore batha. Now we are supposed to investigate why the komore batha is there.
Yeah.
So renal stone per se, if I find a renal stone and the patient is suffering with a chronic low back pain, I can and there is no other findings in the MRI. Judiciously, we can term that the low back pain might be because of the renal stone.
Yes, sir.
There might be because the kidney is gradually getting dilated. If there is a heteronephrosis, then there is always a low back pain.
Yes. Okay. Thank you.
But that part of whether this renal stone per se, whether it can cause chronic low back pain or not?
Not exactly.
Not exactly.
I don't think so.
Yes, sir.
Sir, good evening everyone. Sir, বলছি যে ম্যাক্সিমাম ক্ষেত্রে বাচ্চারা চিলড্রেনরা যখন স্যার ক্লিনিকে আসে এরকম একটা লো ব্যাক পেন নিয়ে আসে কিন্তু আমরা ইনভেস্টিগেশন করতে যাই কোনো রকম কিছুই পাই না কিন্তু এক্সরে বা আর কিছুতে স্যার তো সেটা নিয়ে একটু প্লিজ স্যার
বাচ্চার বয়স এজটা
স্যার
I'll tell you. It is a growing age period. ঠিক আছে? I mean, in fact, in today's date, we are finding right from age 7 to 17. This period of kids are coming to us with low back pain. So, এটা হচ্ছে আমি একটা কথা আগে বলি sedentary lifestyle. আজকালকার বাচ্চারা সকালে ঘুম থেকে ওঠে, their parents prepare them to the school, in the bus, they come back from the school, get a sleep, again go to the tuitions, again come back and sleep, again they carry a huge weight in their bag. So there is a proper guideline that is missing for them. First and foremost is 10% of the body weight should be the bag weight, school bag's weight. Although there is a niyom, it will be coming. So if a child is 30 kilo, the bag should not weigh more than 3 kilos. Do we follow it? We do not follow it. So putting the heavy bag on the shoulders puts a strain on the low back. Along with that, add to that a sedentary lifestyle. There is no exercise. In any type of game you play is a good exercise for the low back. Any type of game you play. But today's kids, unfortunately, do not get a lot of time to play. I'm not talking about just 5, 6, 7, 10 years old. I'm talking about the age till 17, 18. They do not actually get the time to play. So this is quite missing. That is a root cause of the pain. You just counsel the parents to mobilize them to go to swimming, go to cycling, anything for at least 30 minutes a day.
I have a question to Dr. Biswas. In case of traumatic brain injury, sometimes we come across skull-base fractures and CSF leaks. So how do you go about managing this?
CSF leaks basically 7 to 1 week, 2 weeks এর মধ্যে 90% recover হয়ে যায়. যদি more than 2 weeks CSF leakage থাকে, then we avoid cranioplasty and dural leakage blockage with G-patch or pericranium.
So, thank you. So if there is any other questions? Thank you very much. If there is no other questions, we can close the session. Thank you very much our two speakers, two eminent speakers for your enlightening talk on low back pain and traumatic brain injury. We have learned a lot. It was really a interesting and interactive session with both of you. Now we request all of you to join us for the dinner. Thank you very much. Thank you very much for your presence. Thank you and good night to all of you.